Hey guys, welcome back. We are going to continue our hematology discussion with another very important topic, and that is none other than your acute leukemias. We are going to talk in detail about AML, that is acute myeloid leukemia, and ALL, that is acute lymphoid leukemia, their phenotypes, their WHO classification, cytogenetic importance, and the treatment as well. But trust me, it's a kind of a dry area. You're going to have a lot of facts to remember, but nevertheless, it's a very, very important, a crucial area for any exam in the world right now. Let us start our discussion with a kind of a basic introduction. So this kind of a introduction to leukemia. So what is leukemia, first of all? It's nothing but a clonal proliferation of hematopoietic stem cells with failed differentiation. That's the key point here. With failed differentiation into mature elements. And because there is failure of differentiation, you're going to have more immature cells called as blasts in the bone marrow, and they're going to spill over into the peripheral circulation. And because the bone marrow will be full of blasts, immature cells, it will not allow the normal hematopoiesis to occur. That's the reason why you're going to result in cytopenias. And this is going to result in plenty of symptoms like bleeding, infections, anemia, and so on. So what is the epidemiology? So AML is a disease of elderly. As per the data, the median age group at the time the patients are going to be affected with acute myeloid leukemia is going to be approximately 70 years. Usually most of them will be 60 plus. And AML is technically the most common leukemia in adults as of now. And what about ALL? ALL is principally a disease of children, but generally tends to have bimodal distribution. The first peak is going to occur in children less than 15 years of age, and the second peak is going to occur in older adults. But ALL technically is a disease of children, as almost 3/4 of the population that are affected with ALL are going to be children less than 15 years of age. What are the risk factors for the development of leukemias as mentioned in Harrison? Number one, standard risk factors like radiotherapy. Prior exposure to radiation can increase the risk of acute leukemias, and chemotherapeutic agents, the most important. I repeat, the most important are going to be use of alkylating agents and use of topoisomerase 2 inhibitors. These two are very, very important. They can increase the risk of AML as well as other myeloid conditions like myelodysplastic syndrome in the future. So alkylating agents, topoisomerase 2 inhibitors. And benzene has been linked to AML especially, and smoking also has a doubtful association. We don't know for sure. So the most important are going to be radiotherapy, benzene, and chemotherapeutic agents like alkylating agents and topoisomerase 2 inhibitors. And AML as well as sometimes ALL can occur due to some other clonal hematopoietic problems. Like for example, myelodysplastic syndrome. Yes, they can get transformed into acute myeloid leukemia. And myeloproliferative neoplasms, all the myeloproliferative neoplasms including polycythemia, essential thrombocytosis, primary myelofibrosis, and CML, all of those things can develop into a AML in the future, but the risk is going to be very, very high with CML, chronic myeloid leukemia. And we'll talk about CML later on in the myeloproliferative disorders. 2/3 of the CML patients, if they have blast crisis, they will have an AML-like picture, and 1/3 of the CML patients, once they develop blast crisis, they're going to mimic a ALL-like picture. But most commonly, MDS as well as myeloproliferative neoplasms are going to evolve into AML, acute myeloid leukemia. Aplastic anemia is also a clonal problem, and this can also evolve into AML. And paroxysmal nocturnal hemoglobinuria, I think we discussed already, even this can evolve into acute myeloid leukemia in the future. There are some inherited conditions that can increase the risk of development of leukemias in the future. Down syndrome is very, very important. We'll talk about the importance of Down syndrome at the end of the session. So most commonly in exams, they will ask you the acute megakaryocytic leukemia, and we'll discuss about the importance of Down syndrome later on, as I said. So Down syndrome, very, very important. It can result in myeloproliferative disorders, or it can result in myeloid leukemias as well. And it can result in lymphoid leukemias also. And Klinefelter syndrome can also result in acute leukemias, Bloom syndrome, ataxia telangiectasia, which is basically nothing but a cancer syndrome, Lee-Fraumeni syndrome, P53 mutations. All these syndromes we are going to discuss in detail probably in the medical oncology section, not here. And severe congenital neutropenia, that's otherwise called as Kostman syndrome, that can also result in the development of leukemias in the future. And we know that Fanconi anemia doesn't only cause aplastic anemia, there is increased risk of development of leukemias, especially myeloid neoplasms in the future. And Schwachman-Diamond syndrome, again a problem of bone marrow, can result in development of leukemias, dyskeratosis congenita, and of course germline mutations in certain important transcription factors like RUNX1, CBPA, and GATA2 deficiency has also been associated with development of inherited forms of leukemia. These are the examples of inherited germline problems that is going to be associated with leukemia. And how leukemias are going to present? Very, very simple. The most important presentation is going to be cytopenias. That is the reason why they're going to present. For example, if there is anemia, they're going to present with fatigue. And if there is severe neutropenia, they can present with infection. If there is severe thrombocytopenia, they're going to present with bleeding. So all of these three things will be there, but most often they're not. Many patients present with fatigue as the primary complaint. But when you evaluate them for the CBC, they're going to have plenty of other problems as well underneath. And without treatment, acute leukemias are going to be uniformly fatal, almost 100% fatal. There is no remission that you can expect without any treatment. And this is usually due to complete bone marrow failure plus or minus organ infiltration. Organ infiltration, of course, like any other cancer, can occur with leukemias also. We'll talk about that later on. And that can be the reason for death as well. Coming to the clinical features of leukemias. So we need to know what are the things that are going to be common in acute myeloid leukemia and what are the things that are going to be common in acute lymphoid leukemia. So what are the things that are common in AML? Number one, leukostasis. AML tends to produce large sized blasts, number one. Plus at the same time, the blast count may be very, very high in the setting of AML, like more than 50,000. It's more than 50,000 or 1 lakh. Then these cells can go and plug certain capillaries in certain organs. Like for example, if they plug the pulmonary capillaries, they're going to result in shortness of breath, hypoxemia. They can produce pulmonary infiltrates in the chest X-ray. Or if they're going to plug the cerebral capillaries, it can result in headache. If they're going to plug the retinal capillaries, they're going to result in blurred vision and even blindness. And because of the sluggish blood flow in many areas, especially if there is hypoperfusion to the brain, you can result in altered mental status, TIA and or stroke. And DIC is quite common with certain types of AML, especially with acute promyelocytic leukemia. In fact, the usual reason for death in the setting of acute promyelocytic leukemia is DIC. In exam, whenever you talk about DIC and the leukemia, always talk about APL, acute promyelocytic leukemia. The old FAB classification term is AML M3. We know that FAB classification is no longer used, but still many people stick on to the term AML M3 because of the ease of use. But don't use the term, it's better to use the term APL, that is acute promyelocytic leukemia. And patients can have leukemic infiltration of skin or probably gingiva. And if it's going to infiltrate the skin, that's also called as leukemia cutis. We'll see the image. And this is quite common with monocytic subtypes. Previously in the FAB classification, the M4, M5 form. These are the monocytic subtypes. M5 is acute monocytic leukemia. M4 is myelomonocytic leukemia. So these subtypes generally tend to have higher risk of leukemic infiltration of skin and gingiva. And if there is an extramedullary collection of leukemic cells, that is often referred to as scleroma, and can be seen in any location, but as I said, the most common location will be usually the skin. That is extramedullary collection of leukemic cells, and that is otherwise called as scleroma. So these are the things that are going to commonly occur in the setting of acute myeloid leukemia. What are the things that are going to be common in the setting of acute lymphoid leukemia? Number one, bony lumbar pain tends to be more common in ALL, and lymphadenopathy and hepatosplenomegaly usually doesn't occur in the setting of AML or even plasma cell dyscrasias like multiple myeloma. We don't see that much of lymphadenopathy and hepatosplenomegaly, but ALL is very, very notorious for causing lymphadenopathy and hepatosplenomegaly. Sometimes ALL can present just like a lymphoma. That's called as acute lymphoblastic lymphoma. We'll talk about that later on as well. So lymphadenopathy and hepatosplenomegaly, very, very common in ALL. Especially in children, this is very, very common. And ALL, because of the mediastinal lymph node involvement, there is a high risk of development of superior vena cava syndrome. And because ALL blasts are theoretically more proliferative compared to that of the AML blasts, there is an extremely high risk of tumor lysis syndrome in the ALL compared to that of AML. And another notorious aspect of ALL is the CNS involvement. The central nervous system is often referred to as sanctuary sites. Two sites are considered to be sanctuary sites for ALL blasts. One is the central nervous system and second is the testicles. So these are the two important sites that are going to serve as sanctuary sites for ALL blasts. And CNS involvement is seen in approximately 10% of the patients, but at the beginning you may not be able to see any CNS involvement at all. Once you treat the primary blood and bone marrow disease, then the CNS disease might start manifesting. So that's why you have to always be wary of this fact that CNS and testicles are basically sanctuary sites in the setting of ALL. And if there is an obvious CNS involvement, clinically they're going to present with cranial neuropathies, especially sixth nerve involvement. They can have nausea, vomiting, they can have headache, altered mental status, and other signs of raised intracranial pressure. And of course, as I said, they can present like anterior mediastinal mass, especially if it's a T cell AL. The presentation will be very typical of a anterior mediastinal mass that you can see in the X-ray or probably in the CT scan. Here are some images that you may need to know for exams. You can see that there is a leukemic collection in the mouth of this patient, and this is an example of a chloroma. And here's an example of leukemic deposits in the skin, often referred to as leukemia cutis. And you can also notice the gingival infiltration by the leukemic cells. And this is very common in myelomonocytic subtypes, that is M4 and M5. And coming to the workup of leukemia. So first we're going to talk about the peripheral smear. In the peripheral smear, of course, you're going to see cytopenias first. And the WBC count is actually variable. Certain leukemias can present with the normal WBC count. The most notorious is going to be your ALL and sometimes your APL, that is acute promyelocytic leukemia. So ALL, if it's going to present like a lymphoma, not like a leukemia, then your WBC count can be like relatively normal. And acute promyelocytic leukemia again can present with a normal WBC count. So WBCs are variable, but technically in exams you will see like WBCs in the order of like 10,000s and lakhs. But in general, certain types of leukemia can present with a like normal WBC count in the smear as well. But cytopenias are inevitable because the bone marrow will be packed with these leukemic blasts. Plus, the most important thing is in the peripheral smear, in most cases, you're going to see circulating blasts. If it's an acute leukemia, in more than 95% cases, you're going to see circulating blasts. Very rarely, there is a picture called as aleukemic leukemia. That's extremely rare, where you will be seeing only cytopenia, and it's going to present like a aplastic anemia as far as peripheral smear is concerned, where the blast will be only in the bone marrow and there will be not much of circulating blast. That's called aleukemic leukemia. So that's very, very rare entity, but more than 98% of the cases will have circulating blast. And how will you tell whether it's a AML blast or a ALL blast? Just by looking at the blast. Of course, if you see Oyer rods, which are pathognomonic for myeloid blasts, so you can make a diagnosis of AML straight away. And in general, the nuclear cytoplasmic ratio will be less. The NC ratio will be little lesser in AML blasts, which means there will be a decent amount of cytoplasm. There will be a decent amount of cytoplasm with regards to AML blast. But the NC ratio will be very, very high. You don't see Oyer rods, of course, in ALL. And the NC ratio will be very, very high in the setting of ALL blast, which means you will see very little or no cytoplasm at all. The cell will be full of nucleus only and prominent nucleoli. You will be seeing very, very little cytoplasm or inconspicuous cytoplasm with ALL blast. And if there are circulating blasts, straight away you can do peripheral blood flow cytometry itself to find out what is the blast origin. So we don't really wait for the bone marrow. If you see like abnormal circulating cells and if there are enough number of blasts in the peripheral smear, you can do peripheral blood flow cytometry itself. That's going to tell you whether it's AML or ALL blast for sure. Suppose if it's a precursor cell, not very much differentiated, then we know the most important marker, stem cell marker, is going to be CD34. That will be there. Apart from that, CD45 and HLA-DR can be there, but the most important is going to be CD34. And you can confirm that it's a myeloid blast with the help of certain very characteristic myeloid markers like CD13, 33, 117 and myeloperoxidase. This is very, very important in that in exams they will very commonly ask about the CD13 and 33. So if it's a myeloid blast, whether it's a precursor or it's different, the characteristic feature of a myeloid blast in flow cytometry is 1333 positivity and probably CD117 positivity and myeloperoxidase positivity. If it's a monocytic origin, if it's a monocytic blast, M4, M5 type, in the old FAB classification, they're going to have 11B positivity. That's very, very important. That's another very important question in exam. They're going to have CD11B positivity. Apart from that, they can have CD64, CD14, CD15 and so on. But the 11B is going to be the most important. If it's going to be an erythroid blast, they're going to be positive for CD71. That's a very, very important marker that can be asked in exam. It will be positive for CD71 And they can be positive for CD235A also, which is often referred to as something called as glycophorin A, often referred to as glycophorin A. So monocyte, remember that CD11B, erythroid, remember CD71, plus or minus glycophorin A, that is CD235A. And if it's a megakaryoid blast, the CD41 will be definitely positive. That's the exact marker. And if you want, you can remember CD61 also, because CD41 is a GP2B3A. The glycoprotein 2B3A is the one that we called as CD41. So definitely in any platelet and any megakaryocyte, it will be positive. So let me repeat, because this is very important for exams. Precursor CD34, myeloid 1333, monocyte 11B, erythroid 71, and megakaryoid 41, plus or minus 61. So these are the most important markers of myeloid blast. What about the lymphoid blast? Again, if it's a precursor lymphoid blast, so not only 34 will be positive, the TDT will be positive. Like how I said, the 1333 is for your myeloid origin. Likewise, the TDT is of lymphoid origin. That's very, very important. TDT is positive. Usually, you are going to tell that it is a ALL blast, and it's a precursor ALL blast for sure. And apart from that, because these are lymphocytes, you're going to have some additional markers with regards to whether it's a B cell or a T cell. If it's a B cell, of course, the pan B cell marker CD19 will be positive. CD22 usually will be positive, and variably it will be positive for CD10, CD20, CD79A, and usually it will be negative for CD3. That confirms it's a B cell blast. In general, idea is simple for clinical practitioners. I'm not talking about pathologists. Pathologists tend to complicate a lot of things because they need to identify so much. But in clinical practice, CD19 positive, CD3 negative, it's a B cell blast. If you want to know it's a precursor or not, CD34 positivity and TDT positive, that will tell you it's a precursor blast. With B cell, 19 positive, 3 negative, that's it. 22 usually it will be positive in more than 95% cases. Otherwise, other markers are variable. These are important markers as far as your lymphomas are concerned. We'll talk about there in detail, not here. If it's a T cell blast, definitely the pan T cell marker CD3 will be positive, and CD5, 7 will be usually positive. But other markers like CD2, CD4, CD8, these all will be variable. CD1A, these all will be variable. These are also basically markers of T cell origin. So technically CD19 positive, 3 negative B cell blast, 3 positive, 19 negative T cell blast, precursor 34 and TDT. So this is what you need to know. So with flow cytometry, you can easily tell the blast origin pretty much easily. And here is an example of how your AML and ALL blasts look like. You can see that AML blasts are going to have a prominent cytoplasm. Okay, you're going to have a lower NC ratio, and you can see a prominent cytoplasm over here. And the nuclei also will be very, very prominent. You can see the nuclei are going to be very prominent in the setting of AML blast. And another quintessential characteristic feature of AML blast is the presence of IR rods, even though it will be present in the M2, M3, plus or minus M4. If you go later on through M5, M6 and all, the IR rods will come down. If it's very undifferentiated, also IR rods may not be there. But in case if you see IR rods, that is very, very, very characteristic of your myeloid blast. And the maximum number of IR rods will be seen with acute promyelocytic leukemia, APL. APL is the one that's going to have maximum number of IR rod. And if the cytoplasm is packed with IR rods, they are also referred to as something called as Faggot cells. They're also referred to as something called Faggot cells that are very, very common again in acute promyelocytic leukemia. And if you look at the ALL blast, the nuclei may be seen, but it will not be very prominent. And you're going to see an inconspicuous cytoplasm. The NC ratio will be so high that the amount of cytoplasm that you're going to see is going to be very, very less. If not, you won't see any cytoplasm at all. This is characteristic of ALL blast. So in exam, just with the NC ratio, presence of prominent nuclei or not, presence of IR rods, you will be able to tell whether it's a AML blast or a ALL blast. Coming to the bone marrow aspiration findings. Leukemia is a hyperproliferative disorder in the bone marrow. Definitely bone marrow is going to be hypercellular, packed with blast. And as per the criteria, more than 20% blasts are required in the bone marrow to say that it's an acute leukemia. In chronic leukemias, you can have less than 20% blasts, but in acute leukemias, you will definitely have more than 20% blast. And with the help of bone marrow sample, simultaneously you can do the flow cytometric analysis as well. But I don't think it's really required. So mostly we do for cytogenetics only we do bone marrow aspiration. But for flow cytometry, we can do in the peripheral blood itself. We don't want bone marrow for that. Most importantly, we wanted to see the bone marrow to look at the nature of the blast, and most importantly, we wanted the cytogenetics to be done. So that's the reason why we wanted the bone marrow sample, because cytogenetics is best done usually with the bone marrow samples. And presence of certain cytogenetic abnormalities like core binding factor leukemias. What are core binding factor leukemias? So these two are CBF leukemias, or core binding factor leukemias. That is T821 translocation. Previously, it corresponds to AML-M2. AML-M2 is the most common type. So in the FAB classification, if you extrapolate T821, it's going to correspond to AML-M2, and inversion 16, otherwise called as T1616. So usually inversion 16 will correspond to AML-M4E0. That is myelomonocytic type with eosinophilia. So that's the one that's going to correspond to inversion 16 or T1616. So presence of this core binding factor leukemias, these cytogenetic changes, or presence of APL changes, T1517. This is characteristic of acute promyelocytic leukemia or AML-M3. If there are these cytogenetic changes, any one of these cytogenetic changes, if it's there, you are going to diagnose AML regardless of the blast count, which means even if the blast count is less than 20%, it doesn't matter. Any one of these three cytogenetic changes, if it is there, it is equal to AML unless proved otherwise. That's it. And what are the clues with regards to cytochemistry? So this is not at all useful. Only pathologists will be talking in detail about the cytochemistry clues, because in the current practice we use flow cytometry and other cytogenetic markers to diagnose AML and classify AML. So this is something that is historical, but may be asked in exams like NEET SS. That's why I'm mentioning all this. So how will you classify AML and ALL, or how will you identify AML and ALL blasts and some subtypes of AML ALL blasts according to old FAB classification using cytochemistry? So for example, you can stain the sample with myeloperoxidase, and definitely if it's positive, it is AML blast. It's a myeloid blast for sure. And not all the AML blasts will be positive. Some AML blasts, in fact, the earlier AML blasts will be positive for myeloperoxidase, but ALL blasts will definitely not be positive for myeloperoxidase. Sudan black B, again a characteristic stain for myeloid blast. If it's positive, it indicates AML. That's it. It's not going to be ALL. If it's PAS, it can be seen in both AML as well as ALL blast, but the type of staining is going to be clue here. So like for example, if you're going to see characteristic block-like positivity, that's called as block-like PAS positivity. So that is ALL unless proved otherwise. But if you're going to see coarse granular type of positivity, it can tell you whether it is erythroid or megakaryoid blast like M6 or M7. Sometimes the old FAB classification can produce this coarse granular type of PAS positivity. But otherwise, like the most important entity, suppose if they ask an exam, is going to be this block-like positivity. If they tell block-like PAS positivity, that is very much suggestive of a ALL blast. And non-specific esterase again is a marker of your AML blast. Usually it will be positive in monocytoid blast like AML M4, M5. NSE will be positive, but definitely in ALL you won't have NSE positivity. And acid phosphatase is a marker of your ALL blast. It will not be positive for AML blast. And if it is positive in ALL, it is going to produce a characteristic polar staining. So only the poles of the cells will be stained. So that's going to produce a characteristic polar staining. So what are the cytochemistry markers for AML blast? Myeloperoxidase, Sudan black B, PAS, and non-specific esterase. What are the markers for ALL blast? PAS, especially if it's a block-like positivity, and your acid phosphatase. These are the two things that are going to tell that it is a ALL blast. And what are the other investigations that you're going to do in the setting of acute leukemias? So remember, with ALL especially, tumor lysis syndrome is extremely common, but it can occur with AML also. With ALL, it's very, very common. The higher the WBC count, more is going to be the risk of tumor lysis syndrome. And of course, it can be spontaneous tumor lysis, which means the first presentation can be tumor lysis syndrome. Like most of the people think like after starting the chemotherapy only the tumor lysis will occur, but no, sometimes it can be spontaneous. Patients can present for the first time in the emergency with tumor lysis syndrome. We're going to discuss the details of tumor lysis syndrome in the medical oncology section, not here. But nevertheless, what will be the characteristic electrolyte changes? The first clue in tumor lysis will be high LDH. And in fact, this is a very, very, very important marker with regards to the tumor cell turnover. If the LDH is more than 2 times the upper limit of normal, that indicates extremely high cell turnover, and it's going to tell you that the risk of tumor lysis is very, very high, or it's going to tell you that the tumor lysis has already started, but it is subtle as of now. That's all. First marker of tumor lysis is going to be high LDH, especially if it's more than 2 times the upper limit of normal. And of course, you're going to result in that characteristic electrolyte changes like hypocalcemia, hyperuricemia, hyperkalemia, and hyperphosphatemia. You know the reason behind these electrolyte changes, because the tumor cell turnover is high, they're going to produce more purine turnover. That's the reason why they're going to have high uric acid. And you know that the tumor cells, once they are lysed, they're going to release potassium and they're going to release phosphorus also. That's why hyperkalemia and hyperphosphatemia. And phosphorus is going to chelate the calcium, resulting in hypocalcemia. Surprisingly, the total serum calcium can be normal because the phosphorus bound calcium also will be taken into account with the total serum calcium measurement. So it can be surprisingly normal. The ionic calcium is the one that's going to decrease. So you have to look at the ionic calcium one. That's going to give you a more accurate idea about hypercalcemia rather than the total serum calcium. And what is the problem with tumor lysis syndrome? It's going to result in acute kidney injury and arrhythmias. You know, your hyperuricemia and hyperphosphatemia can result in AKI, and hypocalcemia and hyperkalemia can result in arrhythmias. So you have to be careful. This is an emergency. And hypokalemia is quite common with monocytic variants. There are a lot of reasons for why hypokalemia is going to occur with monocytic variants, but one proven hypothesis is the fact that monocytic variants tend to increase the renal wasting of potassium, and that is probably due to the release of lysozyme by the monocytic variants due to tubular damage. This is the point that is given in Harrison, straight line. So monocytic variants can produce hypokalemia, that is due to excessive renal wasting of potassium, and that is because of the renal tubular damage induced by the release of lysosome by these monocytic variants. And if you are dealing with the acute promyelocytic leukemia, always go for a DIC panel because that is the usual reason for death in these patients. So what is the DIC panel going to do? Prothrombin time, partial thromboplastin time, fibrinogen, D-dimer, haptoglobin, bilirubin. So PT and PTT will be increased in DIC, fibrinogen levels will be low, D-dimer and FDP will be high, serum haptoglobin will be low because of free hemoglobin in the system, and bilirubin of course will be high. So this is the characteristic findings that you see in patients with disseminated intravascular coagulation. And lumbar puncture is mandatory for all ALL patients. For all ALL patients, it is mandatory because CNS is a sanctuary site. But you can do in selected AML patients. In AML, it's not always mandatory, but ALL, 100% it should be done because CNS is a sanctuary site. And when will you do lumbar puncture in AML patients, especially those who are having neurological symptoms and signs, you can do lumbar puncture. Otherwise, as I said, in all ALL patients, you have to do lumbar puncture. In case in ALL, if you are doing lumbar puncture, immediately you have to start with intrathecal chemotherapy as a part of standard treatment. We'll talk about the ALL treatment later on. So technically, in any ALL patient, intrathecal chemotherapy is a part of a standard care. And that is because CNS involvement is extremely common. And even if there is no CNS involvement at the time of presentation, because you're doing lumbar puncture, there is an inadvertent risk that via blood leak, you could have pushed some of the blasts into the CSF and that can go into the brain. So that's why to prevent seeding of the blast from traumatic tap, you need to start with intrathecal chemotherapy. Nevertheless, the take-home point is all ALL patients LP mandatory and all ALL patients will receive intrathecal chemotherapy as a part of standard care. That's what you need to know. But it's not true for AML. AML LP is optional and intrathecal chemotherapy is also optional. And you have to do echocardiogram prior because you're going to use some drugs like doxorubicin. Anthracyclines are a very important part of regime of treating leukemias. We'll talk about the regimens later on. Because you're going to use anthracyclines very commonly, you need to definitely obtain prior cardiac history and you need to definitely do echocardiogram. So if there is any severe cardiac dysfunction at the time of starting chemotherapy, it's better to avoid anthracycline component. You can go for other drugs. HLA typing is very, very important in the setting of AML because high-risk patients or patients who are having refractory disease are going to ultimately end up with allogeneic hematopoietic stem cell transplantation, and some patients with very high-risk disease will be receiving an upfront bone marrow transplantation along with chemotherapy. So that's the reason why HLA typing is mandatory. Generally, HLA typing should be done for patients because we need to know their type and we have to do the people around them like siblings, parents and children. Parents and children are not considered to be better grafts because they're going to have only a 50-50 match usually. But siblings are considered to be the best grafts because there can be siblings with a complete match. Your sibling can have a complete match because the parents are the same. So those are called as matched sibling donors. Sometimes it may not be a match, but if you have a matched sibling donor, that's a boon. So having a sibling in the setting of a hematological disorder is a boon. And especially if they are matching, then it's a real boon because in most of the hematological situations, if you want to go for a bone marrow transplantation, the best graft is the matched sibling donor, the best graft. And coming to the WHO classification of AML, currently we no longer use FAB classification system. And accordingly, we have AML with recurrent genetic abnormalities. This is very, very important for exams. Then we have AML with MDS-related changes. You'll have some MDS cytogenetics on top of that. You'll have AML, worse prognosis. And we have treatment-related AML, which can be due to use of prior chemotherapy or radiotherapy. Again, worse prognosis. We have AML not otherwise specified, which doesn't fit into anything at all. And we have something called myeloid sarcoma or scleroma, which is nothing but an extramedullary collection of leukemic cells in some areas. And finally, we have AML that is associated with Down syndrome. That's a separate entity according to WHO. We'll talk about that in detail later on. So what about AML with recurrent cytogenetic abnormalities? We have already discussed about something called as CBF leukemias or core binding factor leukemias, like T821 translocation and T1616 or inversion 16. So T821 is going to correspond to AML M2 of the old FAB phenotype, and your inversion 1616 is going to correspond to the AML M4 ESO of the old FAB type. We have discussed that already. And 821 will involve transcription factors RUNX1, RUNX1 T1, and T1616 will involve translocation of your CBFB gene and MYH11 gene. So both are going to have good prognosis. And we have the third one. These two are called as core binding factor leukemias. And the third one, acute promyelocytic leukemia, that is PML-RARA translocation, is going to involve the translocation in the chromosomes 15, 17. That's why it's called as T15, 17. Together, these three are going to be called as signature AML cytogenetic changes. And if any one of these three things are there, you're going to say that the disease is going to have high cure rates. In the sense, the prognosis will be very good. High cure rates, very, very good prognosis. So signature cytogenetic changes in the sense, if any one of these cytogenetic changes are there, as I told you already, regardless of the blast count, you can make a diagnosis of acute myeloid leukemia. I'll repeat 821, 1616 or inversion 16, 15, 17. Or otherwise, we can call it as RUNX1, RUNX1 T1 translocation, CBFB MYH11 translocations, and we have PML-RARA translocation. And we know that APL, the PML-RARA translocation, is going to correspond to AML M3 of the old FAB phenotype. And I will tell one more thing, that the PML-RARA 1517 translocation, that too the PML-RARA translocation is the one that's going to have a good prognosis. There are other types of APLs that are very, very rare. More than 95% of the times it will be PML-RARA only, but there are some other types of APL due to some other translocations, but they don't have a good prognosis. They don't have a good prognosis. And what about the next one? So whenever you see this term 11Q23 in exam, always think about MLL rearrangements. MLL rearrangements are going to have an intermediate prognosis, not good, not bad. So T911 translocations, that's always called as KMT2A MLL abnormalities or 11Q23 abnormalities, intermediate prognosis. These two have a poor prognosis. They don't have a good prognosis. That is T69, always called as DEC NUP214 translocation or inversion 3 or translocation 33, otherwise called as GATA-MECOM translocations. They are rare, but they're going to have a very, very poor prognosis. And T122 translocation, that is RBM15 MKL1 translocation, are going to characteristically result in the old FAB phenotype AML M7, that is acute megakaryocytic leukemia. And AML with mutated NPM1 is an emerging entity, and AML with biallelic CBPA is also an emerging entity, but AML with biallelic CBPA has a good prognosis, has a reasonably good prognosis. And trust me, the NPM1, nucleophosphine-1 mutations and FLT3 mutations are kind of again signature mutations of AML. You don't see these mutations usually in other cancers. What are the provisional entities that are about to be added in the cytogenetic classification of WHO in the future? One is AML with BCR-ABL1 positivity. Usually ALL is the one that's going to have Philadelphia positivity, but very few AMLs, less than 1 to 2% of AMLs can have Philadelphia positivity, and that's a provisional entity. These cancers can be treated with target therapy like imatinib. And we have AML with mutated RUNX1. So it's not RUNX1 rearrangement, it is mutated RUNX1. Mutation is different from cytogenetic rearrangements. This is mutated RUNX1, baseline mutation. So that is also another provisional entity. And coming to AML with myelodysplastic syndrome related changes. So this can be seen on top of a prior history of myelodysplastic syndrome, which means patient is already a known case of MDS and now developing AML, or patient who is not a known case of MDS and now having AML but having some MDS related cytogenetics. So technically they can have MDS related cytogenetic abnormalities, or they can have morphologic multilineage dysplasia as well. So based on that, you are telling that the patient is having MDS related AML, and technically MDS related AML will have a very, very poor prognosis. And what are the cytogenetic changes with regards to MDS will be discussing separately in the myeloid disorders, not here. Otherwise, it will be very confusing as of now. So, what are the examples of treatment-related AML? We discussed already alkylating agents and topoisomerase 2 inhibitors are going to be associated with development of treatment-related acute myeloid leukemia, and radiation therapy also is going to increase the risk of treatment-related AML. And after radiotherapy or after the use of alkylating agents, it's going to take around 5 to 7 years for the development of AML generally, and it will be usually due to 5q deletion or 7q deletion. These are also kind of MDS related changes only. And after use of topoisomerase inhibitors, it takes around approximately 2 to 3 years in susceptible patients to develop acute myeloid leukemia, and it will be usually due to MLL or RUNX1 rearrangements and mutations. Technically, your treatment-related AML generally tends to have worst cytogenetics, and so that they're going to have a very poor prognosis. Both MDS-related AML as well as treatment-related AML tends to have a very poor prognosis. What about AML not otherwise specified? Now we can take a little bit from the old FAB classification, but trust me, we don't use FAB at all in the recent times. But we are going to take the nomenclatures alone from the old FAB classification. In that, there won't be APL at all here. So first AML without maturation, second AML with minimal maturation, then myelomonocytic AML. No, AML without maturation will correspond to AML M0 in the FAB, and AML with minimal maturation will correspond to AML M1 in the FAB, and myelomonocytic AML will correspond to AML M4. We know monoblastic or monocytic AML will correspond to AML M5, and erythroid leukemia will correspond to AML M6, and megakaryoblast leukemia will correspond to AML M7. And apart from that, the new entities like basophilic leukemia and pan-myelosis with myelofibrosis also there. So these are all other types of AML not otherwise specified. So what do you mean by myeloid sarcoma or chloroma? We have discussed that already. These are nothing but extramedullary involvement by the leukemic blast, and in some patients this can antedate your bone marrow disease, which means this can be the first presentation rather than your bone marrow disease. And this is quite common with monocytic differentiation, we know. So whenever there is peripheral tissue infiltration, that's going to be quite common with monocytic differentiation like myelomonocytic type or proper monoblastic type M4, M5. So what are the types of AML that is associated with your Down syndrome? Initially, as an infant itself, many Down syndrome patients tend to have transient abnormal myelopoiesis called as TAM. And later on, they can develop certain myeloid leukemias, typically AML M7, that is megakaryoblast type. That's going to be associated with Down syndrome. If at all they ask you the most common malignancy with Down syndrome, it's actually ALL only. We'll talk about the data later on. But right now, we are talking about AML. That's why I told, like, initially transient abnormal myelopoiesis. Then, if they develop a myeloid leukemia, it will be usually AML M7, that is acute megakaryoblast leukemia. So, what are the important prognostic markers with regards to AML? So, when you talk about a good risk AML, it is acute promyelocytic leukemia and the CBF leukemias like T821 translocation and inversion 16 translocation. So these are going to be like good risk AML in the sense they have a excellent prognosis and the cure rates are extremely high. In the top of the chart is going to be APL, which has more than 90-95% cure rates. What are the poor risk AML? So any elderly patient age more than 60, AML by default is going to occur in the elderly only, but if the patient is older, the more older they are, the prognosis is going to be more bad. And antecedent myelodysplastic syndrome, treatment-related AML, we know that we're going to have worse prognosis. And if there is a history of myeloproliferative neoplasm like CML, on top of that, if they develop AML, poor prognosis. Like for example, CML developing blast crisis, not so good prognosis. And if they have unfavorable cytogenetics, poor prognosis. Coming to the cytogenetic prognostic markers, we have good, intermediate and poor prognostic markers. When it comes to good prognostic markers, we all know that CBF leukemias, that is core binding factor leukemias, T821 translocations and inversion 16 are going to have very good prognosis, and APL, that too the PML RARA, T1517 is going to have good prognosis. Other types of APL may not have good prognosis. And when it comes to NPM1 and FLT3, mutated NPM1 has good prognosis. Wild type unmutated NPM1, bad prognosis. FLT3, if it is mutated, bad. Unmutated, good. If it is mutated, it's bad prognosis. So combination of mutated NPM1 without FLT3 mutations, good prognosis. The opposite combination, unmutated NPM1 with FLT3 mutations, bad prognosis. Something in between, mutated NPM1 and mutated FLT3, intermediate prognosis. I think you can understand. And biallelic mutation of CEBPA, we have discussed already in the previous slide itself, that's going to have a good prognosis only. And if the patient is having T911 that is MLL rearrangements, 11q23. Rearrangement KMT2A, we discussed already, that's going to have intermediate prognosis. And 45%, which means almost half of the patients with AML tend to have normal cytogenetics. How much ever cytogenetics we have spoken so far, you need to know that almost half of the AML patients tend to have normal cytogenetics. That is going to indicate an intermediate prognosis. Not good, not bad. We already discussed that T69 involving DEC is going to have bad prognosis. Inversion 3 or T33 is going to have bad prognosis. Outside AML, any leukemia, if it contains Philadelphia positivity, it's going to tell bad prognosis only, like ALL, Philadelphia positivity, worst prognosis, AML, Philadelphia positivity, worst prognosis. And loss of whole chromosomes like chromosome 7, 5, 17, these three are very important, 5, 7, 17, bad prognosis. Or parts of these chromosomes like 7q deletion, 5q deletion, bad prognosis. Or the patient is having complex cytogenetics, like more than or equal to 3 clonal abnormalities or monosomy. It's going to tell poor prognosis only. Coming to treatment of AML. So you can split into two, non-APL AML and APL AML. How are you going to treat a non-acute promyelocytic leukemia related AML? So in case the patient is fit, the standard regime is going to be 7+3. The patient is less than 70-75 years. The patient is relatively fit based on the ECOG performance status. Then you can go for the intensive regime, that is the 7+3 regime, one of the most commonly used regimes. So what is 7+3 regime? In the days 1 to 7, you are going to give continuous cytosine arabinocyte, and in days 1 to 3 you are going to give daunorubicin or alternatively idarubicin. So 1 to 7 cytarabine, day 1 to 3 daunorubicin. That's what we call as famous 7+3 protocol. And this is actually a kind of toxic regime, but if you give an appropriate patients, they will do well. In case if the patient is having that signature FLT3 mutations, it could be ITD or TKD. So TKD is tyrosine kinase domain. So if the patient is having FLT3 mutations, no matter what, you can add FLT3 inhibitors like midostaurin. This is a WHO approved drug for the use of FLT3 mutated AML. The patient is additionally having FLT3 mutations from day 8 to 21 after the completion of the 7+3 regime. You can use midostaurin, which is a FLT3 inhibitor. If it's a CBF positive leukemia, we have some special options, like you can add a drug called as gemtuzumab osagamycin, which is a very special drug because it's going to come under a special group of drug called as ADC, that is antibody drug conjugate. So here the gemtuzumab component will be acting as a monoclonal antibody, as the name implies. It's going to bind with CD33 of the myeloid blast. You know, myeloid blast, especially those blasts that are having the CBF cytogenetic changes like 821, inversion 16, are going to show high concentration of CD33. So gemtuzumab is basically going to bind to CD33, and they're going to deliver a drug. That's why it's called drug delivering monoclonal antibody. So it's going to deliver a drug called as osagamycin. Basically, its original name is calichiamycin, which is an anti-tumor antibiotic, but it's a very toxic drug. You cannot give systemically. That's the reason why we are going to target the cancer cells specifically by attaching this toxic drug with the monoclonal antibody called as gemtuzumab. So once gemtuzumab binds with the CD33 of the myeloid blast, this drug will be delivered selectively to the cancer cells alone, thereby reducing systemic toxicity. That's why it's called antibody drug conjugate. More details in the medical oncology section. And in case if it's a secondary AML in the sense we're talking about treatment related AML, or if the patient is having MDS related AML based on the cytogenetics or with history of MDS, then you can use special drug called as CPX351, which is the same as that of your 7+3 combination, but it will have a combination of both liposomal Ara-C and daunorubicin in a perfect 5:1 molar ratio that is going to produce a very high killing effect to the leukemic blast. So CPX351, combination of liposomal cytarabine along with daunorubicin in a perfect 5:1 molar ratio. In case the patient is unfit, like for example ECOG performance status 3, 4, 75 plus years, lots of comorbidities, then the usual therapy that we follow is a less intensive regime with hypomethylating agents like azacitidine or decitabine along with BCL2 inhibitor called as venetoclax. Otherwise, this is also called as a BH3 mimetic. BCL2 inhibitor or BH3 mimetic. Both are the same. It's a pro-apoptotic drug. Hypomethylating agent with azacitidine or decitabine along with venetoclax. Standard treatment for unfit patients. In case the patient cannot receive hypomethylating agents because of certain reasons like prior hypomethylating agent treatment, usually if it's MDS related AML, there's a high chance that patient would have received azacitidine or decitabine already, or on top of liver or kidney disease will not be able to use hypomethylating agents. In that situation, you can try some novel drugs like IDH inhibitors. Isocitrate dehydrogenase mutations can be seen in AML, but it's not signature for AML. It can be seen in other cancers like gliomas also. And in case if this mutation is detected, then you can use IDH1 or IDH2 inhibitors depending on what isoform of the enzyme is mutated. If IDH1 mutation, you can go for ivosidenib. If it's IDH2 mutations, you can go for enasidenib. If the patient is not having IDH mutations, then you can just go for low dose cytosine arabinoside as a initial induction therapy just to support them. Along with that, if there is any sonic hedgehog mutations, you can also opt for sonic hedgehog inhibitors like glastigib. Whenever you have a drug that ends with something called degib, it's a sonic hedgehog inhibitor. So there are plenty of applications of SHH inhibitors in the current practice, but one of the applications is your non-APL type of AML. This is the initial induction regime. So after that, you need to see whether the patient is having a good response or not. CR stands for complete response. What do you mean by complete response? Your absolute neutrophil count should be more than 1000, your platelet count should be more than 1 lakh, and patient should not require any PRBC support for maintaining hemoglobin, and there should be less than 5% blasts in the bone marrow. In that situation, you can definitely start with consolidation therapy. And remember that complete response is not equal to cure. The idea of treating acute leukemia is to cure the leukemia, but CR is not equal to cure. So once you have achieved a CR, now the next step is to see the risk again. So based on the cytogenetics and other features, if it's a favorable risk, then you can consolidate your therapy with high dose cytosine arabinoside, nothing more than that is required. In case if the patient is having intermediate or poor risk markers, then you can push them for allogenic hematopoietic stem cell transplantation, which is better. And in case of refractory or relapse disease, which means initially itself you have not achieved the CR, or if the patient has relapsed again, recurrent disease, in this situation definitely you need to go for repeat mutation analysis, because there could be some new mutations that could be driving the cancers at this point, because cancers are going to have clonal evolution. Any cancer for that matter, they keep evolving over a period of time. The clonal evolution is characteristic of any cancer. So they might accumulate some new mutations that can make the cancers very aggressive. So in case if they are now showing FLT3 mutations, then you can opt for other FLT3 inhibitors like gilteritinib or quizartinib. In case if the patient is having new IDH mutations, then you can try ivosidenib or enasidenib depending on IDH1 or IDH2 mutations. Or alternatively, the patient is not showing FLT3 or IDH mutations for relapsed disease or refractory disease, you can opt for something called as MEC regime. So MEC stands for mitoxantrone, etoposide and cytosine arabinoside regime. Very, very toxic drug. Or you can go for FLAG-IDA, which is very commonly followed in UK and in European countries. What is FLAG-IDA? So here FL stands for fludarabine, A stands for Arasi, that is cytarabine, and G stands for GCSF. It's a very toxic regime. Risk of neutropenia is very high. That's why they have added GCSF also prophylactically. And I stands for idarubicin. So FLAG-IDA, okay, fludarabine, Arasi, GCSF, idarubicin. This is the combination. Or you can also try some newer combination that's mentioned in Harrison, like CLAM regime, which contains clofurabine, which is a purine analog, and we have cytarabine and metaxantrone. These are all very, very toxic combinations. You have to try only in refractory or relapse disease without any mutations to target. So coming to treatment of APL. APL is acute promyelocytic leukemia. We know that. So what I'm going to see in the peripheral smear, I'm going to see atypical promyelocytes. How these promyelocytes will look like? They will be very large. They will have granular cells. We have a granulocytic variant also. I'm not going to talk about that, but generally they'll have a very large cell, granular cells with a typical bilobed kind of a nuclei. And you're going to see this in the blood and the bone marrow. And again, the problem is block in the differentiation. Any leukemia is going to occur because of block in the differentiation. If you look at these cells, you can understand. So here is an example of a characteristic acute promyelocytic leukemia cell. They're going to be large and they're going to have granular cytoplasm, and they're going to have lot of OIR rods, to be honest. Among all the AML spectrum, myeloid blast spectrum, your APL blasts are the ones that are going to have a plenty of OIR rods, and many times you will see that characteristic phagot cells as well. If you want to zoom in, and so you can see that here are the OIR rods, small OIR rods that you're seeing. And on the right side, you have a variant. This is called as A granular variant of APL. But still, you can make it out easily. Even though they are A granular, sometimes they can look like monocytes, but you can see the characteristic bilobed nucleus. That bilobed nucleus is very, very characteristic if it is seen with regards to acute promyelocytic leukemia. And of course, with the help of other flow cytometric markers and CD markers, you'll be able to tell that it is a promyelocyte. And this is a tumor that's going to have excellent prognosis, especially if you have PML-RARA translocation. Other translocations may or may not have a good prognosis. In fact, they didn't have bad prognosis most of the times. And look at the cure rates, it's more than 90%. And that is because this tumor has a distinct tumor biology. So what is the tumor biology? We have discussed time and again, that is T15-17 translocation, PML-RARA translocation. So here that PML RARA fusion protein is going to block the myeloid differentiation at the promyelocyte stage. That is the reason why the bone marrow and blood is filled with a lot of promyelocytes. That's why it is called as acute promyelocytic leukemia. And very rarely, in less than 5% of the cases, you can see variants like NPM RARA fusion. That is because of T517 translocation, or NUMA RARA fusion. That's because of T1117 translocations. And similarly, we have ZBTB16 RARA variant. That's also due to 1117 translocation. So you are going to have the RARA, retinoic acid receptor alpha gene, located in the 17th chromosome. It can fuse with either PML in the chromosome 15, or can fuse with NPM1 in chromosome 5, or can fuse with NUMA or ZBTB16 in the chromosome number 11. It all depends, but if you're going to see the variants, then they may not have good prognosis. In fact, many of these variants don't respond to the standard therapy, and they can portend a poor prognosis as well. And most of the AML cases, especially PML RARA fusions, are going to present with a medical emergency, that is DIC. And in fact, the only thing that's going to stand between you and the death of the patient is going to be your DIC. This is the determining factor of death in most patients with acute promyelocytic leukemia. That is the reason why you should not wait for starting all-trans retinoic acid. The moment you know it is a likely acute promyelocytic leukemia, in the emergency room itself, you have to train your residents to start with ATRA. And most of the patients are going to present with severe bleeding also because of the underlying DIC. As I told you, you have to correct the coagulopathy aggressively with FFP and platelets, because the DIC is the one that kills most of the patients. And don't wait for starting ATRA. Start ATRA in the emergency itself. Don't wait for anyone. If you know it's a APL, start ATRA as soon as possible. That's the treatment of choice. And here is a FISH evidence of your acute promyelocytic leukemia. You can clearly see that the probes for PML and RARA are separate in this. So this is going to tell you that it is normal. But on the other hand, in patients with PML RARA fusion, you can see that the probes are fused. So when the probes are fused, it indicates that PML RARA fusion, and you can easily pick up that in cytogenetics. So this is a characteristic cytogenetic of your acute promyelocytic leukemia. But in exam, they will give you what are the probes. The green probe must be a PML probe, and the red probe must be a RARA probe. So both are fused at one point, so telling that it's a PML RARA fusion. Alright. How you are going to treat acute promyelocytic leukemia? Depending on the risk, whether it's low risk or high risk. So if it's a low risk APL defined as WBC count less than 10,000 at the time of presentation, standard therapy will be all-trans retinoic acid with arsenic trioxide. But in exam, if they ask you drug of choice, that is all-trans retinoic acid only. So we're going to give this as an induction, plus you have to give 4 cycles as consolidation also. And you can see a complete response in almost 100% of all the low risk cases. And overall survival is going to be very, very high. It's almost 99% at 2 years, which means if you have a low risk acute promyelocytic leukemia, it's actually a better leukemia to get compared to other types of leukemia. In patients who are having high risk APL, defined as WBC count more than 10,000 at the time of presentation, ultra and arsenic trioxide alone may not be enough. You need to go for some chemotherapy options also. And we have multiple options in this regards. Like for example, you can go for the standard 7+3 combination, that is Ara-C and daunorubicin combination, or instead of daunorubicin you can use idarubicin, or alternatively you can even go for gemtuzumab osagamycin as well. These are other options, but the idea is that in high risk APL only ATRA and arsenic trioxide may not be enough. You need to add additional chemotherapy also. But if it's a low risk APL, which is the most common scenario at the time of presentation, ATRA and all-trans arsenic trioxide alone is going to be more than enough for most cases. And look at the survival, it is almost 99% at 2 years. So it's one of the leukemias with best prognosis. And in case if you're going to have T1117 ZB TB16 RARA variant, it's not going to respond to all-trans retinoic acid at all. The treatment should be very similar to that of non-APL type of AML. So the T517 NPM RARA fusions and T1117 NUMA RARA fusions remains responsive to ATRA and your arsenic trioxide, but the prognosis may not be that good like your PML RARA fusion. And what about something called as differentiation syndrome? Differentiation syndrome is also called as ATRA syndrome. So what happens the moment you give all-trans retinoic acid, the block is removed and suddenly like all the promyelocytes differentiate into mature neutrophils. That's going to result in cytokine release, and that can result in a lot of problems. Degranulation of neutrophils, cytokine release. So that can result in fever, And these neutrophils go and damage the pulmonary capillaries, resulting in pulmonary infiltrates because of endothelial injury. There will be exudative edema of the alveoli. So patients are going to develop shortness of breath. There will be edema. They can develop hypotension because of sudden increase in the inflammatory markers in the body. And they can develop acute kidney injury as well. So this is what we call as differentiation syndrome or Aatf syndrome. The incidence is almost 25%, which means it's very, very common and it can be asked in exam. Immediate treatment of choice will be dexamethasone, plus or minus you can give diuretics to relieve the edema to some extent, but you need not stop the all-trans retinoic acid. Dexa alone is going to be enough for most cases, but if the reaction is very severe, requiring intubation, severe hypotension and shock, requiring vasopressor support or inotropic support, then in that situation you can stop Atra transiently. Otherwise, no need to stop Atra overall. So after giving Atra, the patient presents with fever, shortness of breath, chest X-ray infiltrates, edema, hypotension and renal failure. Think about differentiation syndrome, or otherwise called as Atra syndrome. Coming to the discussion of acute lymphoblastic lymphoma or leukemia, remember ALL is something that can present as lymphoma also, depending on where the cancer cells are predominantly seen in the blood or in the lymph nodes. So we're going to use the WHO cytogenetic classification. FAB, that is French American British system, is no longer used in practice. It's a very old system devised in 1970s. In 2006 itself, we have completely moved towards the WHO cytogenetic classification system. Accordingly, we have the pre-B ALL type, that is B cell ALL, and pre-T ALL type, that is nothing but the T cell ALL. As you can see, the incidence is going to be more with regards to the pre-B ALL. B cell ALL is the most common, 75%, and T cell ALL is not that common, 20%. Usually, T cell ALLs are going to be common in adults and B cell ALL will be common in children. And technically, the remaining 5%, you can ask, where is the remaining 5%? 75-20, I told you, what is it 5%? 5% is basically the Burkitt's type. Sometimes Burkitt's lymphoma patients can have spillover of the cancer cells in the blood producing leukemia, that's called Burkitt's leukemia. That will fall under the remaining 5%. And the B cell ALL can be extrapolated and it can be told as FAB L1, L2 type. In the past, and pre-TLL also can be extrapolated and you can say it's going to belong to the FAB L1, L2 type according to the French American British system. And the Burkitt's type will fall under the FAB L3 type technically. So what are the different subtypes of your B cell ALL? This is very important because this is the most common, right? So we have ALL with T922, that is Philadelphia type ALL, Philadelphia expressing ALL. There will be BCR-ABL fusion producing BCR-ABL kinase. These ALLs, even though they will be responsive to the tyrosine kinase inhibitors, Philadelphia positivity in any acute leukemia is going to portend a worse prognosis, very poor prognosis, very, very important question in exam. And you have ALL with 11q23 abnormalities. 11q23 abnormalities, that is MLL abnormalities. MLL is otherwise called as KMT2A. Both are the same. In your AML, you saw T911, where MLL fuses with another gene in the 9th chromosome called as MLL-T3. Likewise, here you are going to see T411 very commonly. And remember, MLL is a kind of a transcription factor that is involved in widespread growth of the hematopoietic cells. That's why there could be like 50 plus gene rearrangements with regards to MLL. All of those discussions are not important, but T411 in ALL is important because that's going to portend a poor prognosis. I will never use the term good prognosis in ALL because there is no good risk ALL. It's either standard risk or poor risk. In two diseases, there is no good risk. One is multiple myeloma, second is ALL. No good risk, either standard risk or poor risk. In AML, you can use the term good risk, intermediate risk and poor risk, but in ALL, it's either standard or poor. There is no good. And next one is going to be your ALL with T119 translocation, where there will be fusion of TCF3 and PBX1. TCF3 is also called as elongation factor 2A, E2A PBX1 fusion. And we have ALL with 1221. This is very important, very, very important. ALL with T1221, one of the most common rearrangements that you see in childhood ALL especially. So T1221 will involve ETV6 and RUNX1 fusions. And this is very, very important because it's going to portend a decent prognosis, standard risk. Not good risk, not poor risk, but a standard risk, decent prognosis. And we have ALL with hyperdiploidy, that is cancer cells will have more than 50 chromosomes, decent prognosis again. And we have ALL with hypodiploidy, less than 44 chromosomes in the cancer cells, poor prognosis. Diploidy matters in ALL, poor prognosis. And we have ALL with 514 translocations, otherwise IL-3 immunoglobulin heavy chain fusion. That's the last type. And we have many different cytogenetic types in T cell ALL also, but all of them are not important. Exam, they might be asking you only this, which has a lot of prognostic impact. Even though it contributes only 2% of the cases, it has a lot of prognostic impact. That's T814 translocations. The c-MYC in the 8th chromosome is going to fuse with the T cell receptor alpha gene in the 14th chromosome. So MYC T cell receptor alpha fusion can be seen in 2% of the T cell ALLs. And what are the most important prognostic markers in ALL? When it comes to B cell ALL, the single most important prognostic marker is going to be the Philadelphia positivity. In T cell ALL, the most important prognostic marker is not gene mutations. This is a straight line from Harrison, both of them. And the moment you see Philadelphia positivity, straightforward. In cytogenetics in fish, if you see Philadelphia positivity, there is a fusion of 9 and 22. It indicates a very poor prognosis. Adults alone can express something called Philadelphia. In childhood, usually it will be either Philadelphia positivity or negativity. But adults can have something in between that's called as Philadelphia-like, which means in cytogenetics and fish, you will not see any fusion, frank fusion of the genes in the chromosomes. But they still express the BCR-able kinase. And that can be picked up in something called as gene expression profiling, GEP. So that's called Philadelphia-like, not frank cytogenetic changes. In fish, you will not be able to pick up much, but in gene expression profile, you will be able to see there are some genes that are producing BCR-able-like kinase. So that's called Philadelphia-like. That's quite common in adults. So prognosis-wise, Philadelphia negative, standard risk. Philadelphia positive, worst prognosis. Somewhere in between, you can place the Philadelphia-like. And Philadelphia-like disease, as I said, is common in adults. And when it comes to T cell ALL, the notch gene mutations are going to be more important. And it's important to understand that in infants, the MLL rearrangements are quite common, which is not going to portend a very good prognosis. But in childhood ALL, as I said, the ETV, RUNX1 rearrangements are quite common and they portend a decent prognosis, not so bad prognosis. Other rearrangements that you have seen are common in adults. In infants, most common is MLL, 11q23 abnormalities. In children, it is the ETV6 RUNX1 fusions that's common, decent prognosis. All other things can be seen in adults. Let us revisit the clinical points with regards to ALL. First of all, we need to know that the CNS involvement is quite common in ALL, and CNS and testicles in males can be acting as sanctuary sites for this leukemic blast. And that's the reason why lumbar puncture is mandatory for anyone with ALL, and testicular examination is a must for all patients with ALL. And one has to definitely do a CT chest to rule out the mediastinal mass, which is very common in T cell ALL, because T cell ALL tends to present as mediastinal lymphadenopathy. And this is of prognostic significance because it can compress the SVC and can present with SVC syndrome. And lymphadenopathy and hepatosplenomegaly are also quite common in ALL compared to that of AML. And theoretically, ALL cells tend to have a higher proliferation rate compared to AML cells. That's why the tumor lysis syndrome is very common in ALL, especially if the count is very high. And DIC and leukostasis are rare because ALL cells are little smaller. So leukostasis risk is not that common, and DIC risk is also not that much in the setting of ALL, but still it can occur, especially if the WBC count is more than 1 lakh. If the WBC count is very high, we have seen ALL patients with 3 lakhs, 4 lakhs WBC count. In those situations, leukostasis can occur and even DIC can occur because of endothelial injury. And as I've been mentioning from the beginning that there is nothing called as good risk ALL. It's either standard risk or poor risk. That's it. In general, children are going to do better compared to that of adults. And as I said, ETV6 rearrangements, which are the most common rearrangements that you see in childhood ALL, tend to portend a relatively better prognosis compared to other cytogenetic changes. What are the high-risk features? I told you already, whenever there is MLL KMT2A translocations, it's a poor prognostic marker, Philadelphia positivity, or sometimes Philadelphia-like expression is also going to tell you a not so good prognosis. And a complex karyotype, 3-4 changes seen in the cancer cell is also going to tell you a poor prognosis. Hypodiploidy, as I've told you already, less than 44 chromosomes in the cancer cells, poor prognosis. Early T cell phenotype. So this is something I have not mentioned, but you can remember now. Early T cell, ETP, early T cell phenotype, poor prognosis, high risk feature. And if the patient is having minimal residual disease, that is, some disease is left even after induction therapy. So that's also going to tell you a poor prognosis. Presence of minimal residual disease after induction therapy, poor prognosis. How you are going to treat ALL? So for induction, maintenance, as well as consolidation therapy, we don't have any standard regime. As of now, no standard consensus. Guidelines say that you have to enroll the patient in a clinical trial. But commonly what we are going to follow is a multi-agent chemo, just like any other cancer. So what are the common regimes we follow for induction therapy? So that is called VPDA regime. VPDA includes vincristine, prednisolone, daunorubicin, and asparaginase. So asparaginase can be either L-asparaginase or PEG-asparaginase, but in the modern era, we prefer PEG-asparaginase because of the low rate of side effects. But one important side effect that you have to look for with asparaginase is pancreatitis that can be asked in exams. And as we know that CRS prophylaxis is mandatory for all patients with ALL, If you look at induction therapy or post-remission treatment, either consolidation or maintenance, whatever may be the treatment of ALL, whatever may be the stage of treatment of ALL, it doesn't matter. You can see everywhere there will be intrathecal treatment. Intrathecal treatment. Intrathecal methotrexate will be given for every single patient with ALL during any stage of treatment because of the very high risk of CNS involvement in the setting of ALL. That is the reason. So how we are going to treat the CNS disease? So in case, even if it is not there at the time of presentation, still we'll give CNS prophylaxis for anyone with ALL. So that should be done with either intrathecal methotrexate plus or minus Aracid, that is cytarabine or cytosine arabinosid. Everything is the same. And in some patients, you can additionally opt for whole brain irradiation also. That's called as cranial radiotherapy. We'll talk about that in detail, the radiation oncology section later on. And in case if the patient is Philadelphia positive, of course, this is going to portend a very poor prognosis, but they tend to respond to tyrosine kinase inhibitors like imatinib or dasatinib. We'll talk about what are the TKs that are effective if Philadelphia positive in the CML section. If the patient is more than 40 years of age, little older adults, then in that situation, you can try a regime called as hyper-CVAD regime. So what is hyper-CVAD? You are going to use hyperfractionated cyclophosphamide, vincristine, doxorubicin and dexamethasone. These are the drugs that you're going to try. Coming to the post-remission treatment, the treatment will depend on whether the patient is having a standard risk ALL or a high risk ALL. In case the patient is having a high risk ALL, then it's better to opt for an upfront hematopoietic stem cell transplantation because this offers the best chance of achieving a cure in patients who are at high risk. Whenever you see the high risk feature that we have discussed in the previous slide, offer a upfront allogenic hematopoietic stem cell transplantation. If the patient is having a standard risk ALL, then further treatment can be divided into either consolidation, intensification chemo and your maintenance chemo. So the details of this regime are not important even at an SS level because these are DM level stuff, but nevertheless, your consolidation chemo will be for 7 months and the maintenance chemo will be there for next 2 to 3 years. Usually consolidation or intensification chemo in India is done with cytarabine, etoposide, asparaginase, of course along with intrathecal methotrexate, and maintenance chemo will be done with vincristine, prednisolone and 6-mercaptopurine along with definitely oral and intrathecal methotrexate. And how will you treat relapsed or refractory ALL? Especially patients who are having persistent minimal residual disease. If you pick up a MRD, definitely it will be called as relapsed or refractory disease only. And for that, first you need to go for a salvage treatment. Once the salvage treatment is effective, then you can offer a allogenic hematopoietic stem cell transplantation. So what are the salvage options for these patients? These are the modern options. Only the drugs part they can ask you in exam. For B-cell ALLs that are relapsed or refractory, we can choose an option called as blinatumomab. It's not available in India right now. You have to import. It's very, very costly. That's called as CD19 BiTE. What do you mean by BiTE? BiTE stands for bispecific T-cell engagers. If you look at this image, you'll understand things better. So these monoclonal antibodies, special monoclonal antibodies or BiTE monoclonal antibodies are going to bind with 2 proteins on either side. For example, on one side, it's going to bind with the CD19 of the cancer cell. Because you're talking about B-cell ALLs, definitely they're going to express CD19. So they're going to bind to the CD19 of the cancer cell. And on the other side, it will bind to the CD3 receptor of the T cells of the patient. And the cancer cell will be brought together with the T cell so that interaction will increase and immune-mediated destruction will occur. So that is the idea. So blinatumomab is a special monoclonal antibody called as BiTE, that is bispecific T cell engager. Then we have something called inotuzumab ozagamycin, which is a antibody drug conjugate like your gemtuzumab ozagamycin that we have discussed already. But here the inotuzumab component is going to bind with the CD22 of the leukemic blast and it's going to deliver the toxic drug calicamycin to the cancer cell selectively, just like your gemtuzumab ozagamycin. And we have another modern drug called as tisacel. Even though the name can be quite complex, that's called as tisagenlecleucel. So that's the real name, but to keep it simple, we call it as tisacel, that's all. So this is basically a CD19 CAR T therapy. So what is CAR T therapy? That is chimeric antigen receptor T cell therapy. So here, what the drug is going to do? So first of all, how the drug is formed, we are going to extract the T cells from the patient and we're going to genetically engineer in the lab. So what genetic engineering we are going to do? We are going to change the structure of the T cell receptor. So once the T cell receptor is changed, we can actually target the antigen that we wanted to target. So for example, we are going to engineer the T cell receptor in the lab in such a way that's going to target the CD19. Now the T cell receptor of this genetically engineered T cell is going to recognize the CD19 of the cancer cell, effectively killing them. That's why this is also called as CAR T therapy or chimeric antigen receptor T cell therapy. It's very, very costly. It's not available in India right now, nevertheless, but these are options for this patient. That's a CD19 CAR T therapy. In case the patient is Philadelphia positive, of course, you can additionally offer a tyrosine kinase inhibitor like dasatinib, nilotinib, etc. What are the options for your advanced T cell ALL? We have a newer purine analog called as nelarabine that can be offered. And for both B and T cell ALLs, we can offer chemotherapy options like high dose cytarabine containing chemotherapy, or we can opt for a newer purine analog called as clofarabine. So this is the usual situation in Indian practice as of now, because the other drugs that I mentioned are not commonly available in Indian practice, or if you want to import, they are going to be extremely costly, where many patients may not be affordable for them. And the last slide that we're going to talk about is a special case situation. What are the cancers that are going to occur in the setting of Down syndrome, that is trisomy 21. The most common leukemia in Down syndrome is actually ALL, but that's going to occur after 4 to 5 years of age, but before 10 years of age in most patients, if at all it's going to occur. But the characteristic cancer in patients with Down syndrome is the AML M7, acute megakaryocytic leukemia or acute megakaryocytic leukemia. So initially, many patients with Down syndrome will have something called as TMD, that's called transient myeloproliferative disorder, and they're not going to present any symptoms. Typically, it will be detected incidentally in the neonatal period, and you're going to detect just with the help of routine CBC screening, nothing more than that. And you're going to see circulating blasts in the peripheral smear, and most of them will be typically megakaryoblast. And as I said, most of them will be totally asymptomatic. It's an incidental finding. Plus or minus, they can have mild cytopenias like anemia, thrombocytopenia, but apart from that, very few, this is very rare, very few can have severe organ damage like renal failure or cardiopulmonary failure and DIC, disseminated intravascular coagulation. But otherwise, most of the patients, 90% plus patients, will be completely asymptomatic. And this is a mutation that's very important for exam. Most of them are going to show GATA1 mutations that can have problems in the exon 2 or exon 3 of the GATA1, and GATA1 is coded by X chromosome. GATA1 is a very important transcription factor with regards to hematopoietic cell growth, especially your megakaryoblast. And most of these TMDs, transient myeloproliferative disorders, are going to resolve by approximately 2 to 3 months. But there is a 20% risk of transformation to AML M7, that is acute megakaryocytic leukemia, before 4 years of age. So definitely you have to follow these people very closely. In 2 to 3 months, the blast will disappear in the peripheral circulation, and the cytopenias also will disappear if there are any. But still, these patients are at 20% risk of getting transformed into AML M7 type, AMKL, before 4 years of age. And now coming to AMKL, that is acute megakaryocytic leukemia. Most of them are going to present before 4 years of age. And as I said, the GATA1 mutations are the commonest, and that is the one that will be seen in almost all the patients with acute megakaryocytic leukemia. And look at the risk, even though this is not the most common leukemia in Down syndrome patients, but the risk is increased by approximately 500 times compared to children without Down syndrome. So that's why this is a very important cancer and a characteristic cancer of Down syndrome. ALL may be the most common, but it's not a typical Down syndrome tumor. Typical and a characteristic specific tumor of Down syndrome is AMKL, acute megakaryocytic leukemia. And how they're going to present, of course, like any other leukemia, they're going to present with progressive cytopenias, but these patients tend to have very severe thrombocytopenia and anemia. And patients are going to have bone marrow fibrosis also. The reason for bone marrow fibrosis is excessive production of PDGF, platelet-derived growth factor, by your megakaryoblast. And because the bone marrow is not producing any viable hematopoietic cells, the extramedullary hematopoiesis will take over, and you're going to result in a gross hepatosplenomegaly, and the tumor burden itself will cause a gross hepatosplenomegaly. And you can also see a leukoerythroblastic picture because of bone marrow fibrosis. But overall, this is a tumor that's going to have a decent prognosis. In fact, an excellent prognosis treatment. But you need to understand that Down syndrome children are very sensitive to chemotherapy. You cannot use a very high intensity chemo like used for other children. You have to use a low intensity chemo for these children because they have higher treatment related mortality. Even though the prognosis, the cancer responds well to treatment, these children die because of the treatment itself. That's why use of low intensity chemo is very important in children with Down syndrome. Coming to ALL in Down syndrome, we know that the most common leukemia in the setting of Down syndrome, and the risk is increased by approximately 10 to 20 times compared to children without Down syndrome. And what will be the genetic abnormalities with Down syndrome related ALL. The most common abnormality as mentioned in Harrison is CRLF2 overexpression. CRLF2 overexpression is the most common abnormality. This is usually not seen in other ALLs without Down syndrome. Plus or minus, they can also have the peculiar JAK2 mutations. In children without Down syndrome, we know the ETV-RUNX1 translocations. ETV-RUNX1 fusions are the most common, and trisomies are the most common. But in patients with Down syndrome, the CRLF2 overexpression plus or minus JAK2 mutations are going to be the most common. Very important question in exam because that's a straight line from Harrison again. Most of the patients with Down syndrome will develop ALL before 10 years of age if they are about to develop ALL, and majority of them as expected will be a B cell ALL and not a T cell ALL. And the ALL with regards to Down syndrome, as usual, it's going to respond very well to chemo, but these patients are very sensitive to chemotherapy. Because of that, they're going to have high treatment related mortality, and that is the reason I've been telling repeatedly from the beginning that you have to go for low intensity chemo in the setting of Down syndrome, not a full high intensity chemo that we use for other children. And a lot of important points are there in Down syndrome also with regards to your acute leukemias, and that can be asked in exams. These are the crux of what can be asked in exams. I don't think anything else will be asked, to be honest, when it comes to acute leukemias. If you are thorough with all the information I have said, then nothing more is required for SS exams. And thank you very much. Let us move on to the next section. Thank you.